Well, thank you for being here on such a lovely day. So I'm going to be going through a lot of information in a short period of time. So if you have questions later, I'll be around because I'm going to be probably using terms and things that you may not have heard about in the past. Anyway, so my field is all about babies, and this is the most famous baby in our field. This is Louise Brown, who was born July 25th, 1978. And because of this, the science behind this, Dr. Edwards actually won the Nobel Prize in 2010. So this actually was a really significant breakthrough. And this is a big year. So Louise Brown is 40 in just a couple months, and I was able to meet her at our fertility meeting. And she wrote a book, so if you're interested in what it was like to be the first IVF baby, the book just came out last year. So there are a number of milestones in the field of assisted reproductive technologies. The first baby, as I've mentioned, the first one in the US was in 1981. And then the first from a frozen embryo was in '84. Same year, also the first time that there was an embryo transfer to a surrogate, and the first baby from IVF with donor egg. And in 1986 was the first baby born from a frozen egg, the first from preimplantation genetic diagnosis in 1990, and then the first baby from intracytoplasmic sperm injection, which I will go into a little bit later. So I think most of us are aware of this in general. We know that fertility does change over the lifespan, so even the most fertile woman eventually becomes infertile. I think a lot of people don't realize how quickly this change happens, especially, is the pointer? I guess the pointer isn't working. Oh, okay. So as women get further into their 30s, fertility starts to decline, and then it goes down very rapidly as women get into their early 40s. And by the time women are in their mid-40s, pregnancy is very, very rare. We have also been seeing a big change in the demographics and when women are having their children. So you can see women are definitely having their children later, and this is happening all around the world. So you can see how things have just changed from the 70s until 2009 when this data was presented. So there are many countries now where women are having their first child in their early 30s. And even when we're doing our best to optimize fertility, we still cannot overcome this decline with aging of the eggs. So even doing IVF, we still see this decline in fertility. Now, if someone has eggs frozen from when they're young or they're using a young egg donor, the pregnancy rates stay high. So as you'll see a little bit later, as long as someone still is alive, they can get pregnant. So in the last few years, there's been a lot of attention on freezing eggs, so it's even been in business journals. And a few years ago, I was trying to convince President Hennessy, when he was still president, that it would be good to cover this for people at the university. So I actually sent him this article. So it is, gotten a lot of attention. I think more and more people are aware that this is an option that you can consider freezing your eggs. And one of my colleagues at NYU looked at the reason why women were freezing eggs, and they found that for the most part that it was because of a lack of a partner. Professional reasons, other reasons factored in, and some women had multiple reasons, but for most it was the lack of a partner. And I've been doing a project with a medical anthropologist at Yale, and we've interviewed a lot of our patients, and that is what we have found. There's also a writer John Berger, who's written a book called Datanomics, and he has noticed that, a lot of women that he, he was surprised that they were freezing eggs, but he looked at kind of the demographics. In the U.S., in the 20 to 29-year-old age group, there are 1 million more college-educated women than men. So that's, I think, created a lot of this increase in women thinking about freezing their eggs. When someone comes in and they're interested in what their ovarian function is, what their reserve is, we are able to do some testing to give them an idea of how well they may respond to our medications, how many eggs they may get. We know that the best assessment of quality is just age. So as women get older, the eggs are more likely to be chromosomally abnormal, and so that is the big reason why fertility declines. So even when women are ovulating in their 40s, we know most of the eggs are just chromosomally abnormal. So that is the reason why the fertility declines so much. There are different measures of ovarian reserve. The traditional was to look at FSH and estradiol levels early in the menstrual cycle. So if the FSH level was high, that was usually correlated with a poor outcome. And then we can do an ultrasound to look at the ovaries. And if the ovaries are really healthy, they'll be very large and plump and have a lot of these little black spots, these little resting follicles. But as women get older, the ovaries get smaller as women lose their eggs, and the number of these little resting follicles decreases. The most common test that we're using now is this blood test called Anti-Mullerian Hormone. And the reason why that, I think, has become so commonly used is that it doesn't change very much during the menstrual cycle. It also is not affected as much by being on oral contraceptives. Because you can do it any time in the menstrual cycle, it's just an easier test to do. And it probably is a little bit more predictive earlier than the FSH level. When women are thinking about if they're thinking about freezing eggs, they want to know how many they should freeze. And there's no one answer to that. We usually feel safer having more frozen, but there's no guarantee, no matter how many eggs someone has, that they will end up with a child. If women have very low egg supply to start with, so if they're older, they may only get 1 or 2 eggs in a retrieval, and that's probably not going to give them a very good outcome in the future. There are a number of different graphs that people use, and this is one just showing how pregnancy rates really go down with aging and how you need many more eggs. So to look at this a little bit better, if you want to have a 75% chance of pregnancy and you're 34, 10 eggs will probably do that. If you're 42, you need 61. And that is because so many of those eggs are just not going to be healthy. The chance of pregnancy, so if you have 20 eggs frozen at 34, that would give you probably around a 90% chance. At 37, a 75% chance. And at 42, only a 37% chance. So obviously, if you're going to freeze eggs, it's better to do it when you're younger. But then if you're doing it when you're younger, there's less of a chance that you may need to use them. The process to freeze eggs is not a huge process. It takes about 2 weeks to do. And what we do is we give medications. So we actually give follicle-stimulating hormone. So the hormone that a woman is producing, we give a little bit more to keep more eggs growing. So normally 1 egg grows and a bunch of eggs regress each month. So we give, so the woman learns how to give these medications. They're very easy to do. They're little subcutaneous injections. And it usually is about 10 days of those daily injections. We add a medication called a GnRH antagonist when the leading follicles are usually about 14 millimeters, and that's usually after about 5 to 7 days of the injections. And then when the ovaries are ready, we give the final trigger shot of HCG to get the eggs to mature so that they will come out when we do the retrieval. And then we do the retrieval 35 to 36 hours after that injection. So that timing has to be fairly precise. If you do it too early, the eggs won't come out. And if you wait too long, then the eggs are released and you can't get them. This is what we hope the eggs will look like, or the ovaries will look like at the time of the retrieval. So all those black circles are follicles. You can't see the egg, but usually when the follicles look like that, there should be a mature egg inside. So the retrieval is a vaginal procedure. We use a needle we use a 17 gauge needle, so a little bit thicker than what's used to draw blood. And then the fluid is aspirated from the follicle, and then we hand off that fluid to the embryologist who's looking under the microscope, and hopefully that's what she finds. So that's what the egg looks like right after it's retrieved. It has all of these support cells. When we freeze it, we take those support cells and we just freeze the egg by itself. Freezing eggs, like I said at the very beginning, the first live birth was in 1986, and the initial success rates were terrible. So if you read about egg freezing, you still may hear people say, oh, it just doesn't work, it's not very efficient. And that was true initially. So it was very difficult because the egg is a big cell, it's hard to freeze. Another one of the problems was that when the egg was thawed, it just wouldn't fertilize. Because the shell around the egg changes with the cryoprotectant, when they would do conventional IVF, they just couldn't get fertilization. So people gave up for a number of years, and then there were some changes that I'll show in a second, and that resulted in a lot of renewed interest. We started doing it back in 1999, so we were the first center to do it west of the Mississippi, and the first to do it specifically for cancer patients. And I'll talk about that in a few minutes. So these are some of the changes that resulted in egg freezing becoming very effective. So we were able to change some of the cryoprotectants. Probably the biggest thing, though, was this fertilization technique called intracytoplasmic sperm injection. So this was developed in the early 1990s, and initially for men with very low sperm counts. And what you do is you take one sperm and then you just inject it directly into the egg. When people first started doing this, people were amazed that it worked because it bypasses the normal fertilization process. But this actually works very well for men with low sperm counts, and it works very well for eggs that have been frozen and thawed. So once people were able to get fertilization, then there was a lot of renewed interest, and people started to develop new tools to make the process more efficient. So there are two techniques. There's the slow freezing technique, which is what we initially started using, and then most people moved to vitrification, which is like a snap freeze. So you can see this is a slide that my friend at NYU made showing the very early years of egg freezing. And so you can see in the first decade, there were a handful of pregnancies, and they were always slow freezing. And then around 2003, people started, to use some vitrification. And then by 2000 to 2008, it really took off. And most pregnancies now are from eggs that have been vitrified. So most people have switched to that method. And it does seem to work better than the slow freezing, although there are some centers that still do it and report good results. Our organization considered this experimental until the end of 2012. So this came out early 2013, saying that it was no longer considered experimental in the US. Other countries were doing it more routinely. A lot of the data that this was based on came from Italy, because for many years you could not freeze embryos, you could only freeze eggs in Italy. So they had a lot of experience because they did not have the option of freezing embryos. People have looked at the health of children from frozen eggs, and from the first 900 that were reported, there's a very low risk of birth anomalies, and that actually is a very low rate. So there's no increase in adverse outcomes that anyone has reported to date. And this is how they're stored. So they're different storage tanks, but they're kept in tanks that are filled with liquid nitrogen. This is the type of tank that we keep our embryos in. And then, so they can be stored for long periods of time, probably for hundreds of years. And then when a patient wants to use them, then they'll come back and fertilize them. So this is what the embryo looks like the day after fertilization. And then 3 days after, it will hopefully have about 8 cells. And then 5 days later, it'll be at the blastocyst stage. So that is what normal embryo development looks like. So when patients are selecting the best embryo, and you'll see if you look at the multiple rate doing IVF in the US, we used to have a lot of patients having twins, triplets, you even hear of quadruplets. So initially we weren't that good at selecting the best embryo. And so you could have a bunch of embryos, and these are all actually really pretty embryos. So these are all 8 cells and pretty evenly divided. So these are really nice embryos. And in someone who is 40, the potential is going to be lower per embryo than someone who's 30, but you don't really know, and so patients would just want a lot transferred. So there are things that we've done to try to select the embryos better. So culturing them to blastocysts gives us more information. The longer that they grow in the lab, just the more likely they are to continue on when they're in the uterus. So we can select them better that way, because we really do want to avoid this. So our guidelines are so you can see that in older patients, if we haven't done genetic screening on them, if they're over 40, we can transfer up to 5, because we know at age 40, usually at least half of the eggs are chromosomally abnormal. But if we do genetic screening, then the recommendation is just to transfer one at a time. And as much as possible, we are transferring one embryo at a time. So pre-implantation genetic diagnosis is the way that we're able to tell if the embryo is chromosomally normal. So the biopsies of the embryos are done for different reasons. So a lot of patients may be doing it because they carry a disease that they don't want to pass on. And I see a lot of cancer patients, and today I was talking to a patient who's a BRCA carrier, so she doesn't want to pass on the BRCA mutation. So people will come in because they don't want to pass a disease on. Testing for chromosome abnormalities is a little bit variable. There's some people who test all of the embryos, and then there's some clinics that don't do that testing on anyone. So that role is still a little bit gray, and there still is a lot of debate in our field about when to do this. But if you do the testing, then we know that the implantation is very high. So it actually does help us select the embryos a little better. So this is what the biopsy looks like. We just make a little slit in the shell around the embryo, take a few cells, and then we can test for either the disease that the patient may carry or test for chromosomal abnormalities. So there are a lot of patients who can benefit from egg freezing, and this was one of my first cancer patients. She was diagnosed with tongue cancer in her early 20s and had a recurrence and was going to need really aggressive chemotherapy. Right before she started her chemotherapy, she read that it could cause infertility. So she found out that we were freezing eggs, and she came and froze her eggs. And then because of that, she decided to start an organization to get information to other cancer patients because she had found it so difficult to find out about it. So she started this, and it actually was amazing at how she was able to get oncologists across the country to start thinking more about referring cancer patients. And this then became part of the Livestrong Foundation. So if you're interested in information for cancer patients, this is actually a really good resource. So if a cancer patient comes in and they want to know what their risk of ovarian failure is, we look at their age, the type of chemotherapy. There's some types of chemotherapy that are much more toxic to the ovary than others. If they're having pelvic surgery or radiation, those also can really decrease their fertility. So depending on their situation, they may or may not even need to freeze eggs. So we know that there are a lot of women who are diagnosed with cancer every year. So this year, almost 900,000 women will be diagnosed. And there are a lot of young cancer survivors because the pediatric oncologists have gotten so good at treating these patients. So years ago, when the treatment for a lot of these cancers were not very good, most of these patients did not survive. But now that so many of these patients survive, these quality of life issues are extremely important to them. And this was a quote from one of our patients here in the Children's Hospital. When they told me I had cancer, I didn't cry. When they told me I had a 50% chance of infertility, I cried like a baby. And I see this all the time. I have a lot of patients who come in. Obviously, they're devastated by their cancer diagnosis, but to realize that it may affect them from having children in the future is, I think, is the worst blow for a lot of them. Okay, so this is just showing the impact that chemotherapy has in the group of patients that I see the most, in the breast cancer patients. So you can see patients who get standard chemotherapy for breast cancer, you'll see that a lot of them will start to have menopause even in their late 40s. Usually if they're getting chemotherapy and they're in their mid or early to mid 40s, almost all of them will go into menopause right after. So for breast cancer patients, this is usually a really important thing to do before they get their standard chemotherapy. So there are different options. So egg freezing is what is available or makes the most sense, I think, for a lot of these patients. If they do have a partner, they can freeze embryos. We have been counseling patients a little bit more against doing that because of some of these lawsuits that have happened in the last few years. So if relationships fall apart and they have embryos, there have been a lot of disagreements about how to use them. So more and more we're recommending that women freeze eggs, and it just makes it simpler in the future if there is some change in their relationship. There are other things that we can do for these patients. We can freeze tissue that's still considered experimental, and then hopefully in the future we will be able to mature these eggs in the future and then freeze them as mature eggs. So the other patient population that has benefited from being able to freeze eggs is the transgender community. Now, Thomas Beatty was really important in, I think, getting people to think about how family building was important in this patient population. So he actually did not need to freeze eggs or do any invasive techniques. So he did inseminations, but he, I think, made people aware of the fact that you could start testosterone, stop it, and then you could still carry a pregnancy. So there have been a number of patients who have done that, and I've seen quite a few over the years who had been on testosterone and then stopped and were able to carry a pregnancy. A lot of these younger patients, though, are coming in before they start their testosterone just to freeze eggs before so they don't have to think about it later. Or if they're having their ovaries removed, then they want to freeze eggs before then. So depending on their situation, there are different options. So for patients who are going female to male, they can freeze eggs, embryos, or ovarian tissue. Eggs is probably what is probably the most useful for most of these patients. And like I said, there have been a number of patients who have had ovarian recovery after being on testosterone. So even if someone started testosterone, like some of these young patients that I see, they could stop, and then if they were going to have their ovaries removed, freeze eggs when they're a little bit older, if they're not quite ready to make that decision as a teenager. Let's see, so I guess I'm almost out of time, but one thing, because we have all these patients now who can freeze eggs in all these different situations, it does bring us up to this issue of, how old is too old. So this is probably the oldest reported pregnancy. Now, she used donor eggs, which Dr. Agajanova is going to talk about after this. But she was 70 and had twins because she wanted to have a male heir. So it is possible for women to get pregnant at any age. And these technologies, as more and more women are freezing eggs, I think we're going to have to think about some of these issues a little bit more. And we do know that as women are living longer, there are more women thinking about having children later. The oldest patient I've had call me was a patient from Denmark who was 65. Her father was 95. And so she said, she was going to live a long time still, and so she didn't think there was any reason why, she shouldn't be able to do it. And most people do think they are much young, or they feel much younger than they really are. And our professional organization says that that age 55 is generally the upper age limit. Now, around the world, there are places that will do it at older ages, but that is the cutoff that we use in our clinic, and that's pretty much what most people in the U.S., somewhere between 50 and 55 is usually the upper cutoff. So just a few final thoughts. So egg freezing actually is quite successful, and there's a lot of diversity in who can benefit from these techniques that we can do. There are a lot of ethical issues that are coming about because of this, and the laws do seem to lag behind some of the things that we are doing, which is why you may see some of these lawsuits coming up in the future. And I guess we're out of time. Thank you.